Good morning, everyone. Welcome to this sponsored symposium by Elixir Medical. I am Michael Lee from Queen Elizabeth Hospital, Hong Kong, and co-chairing with me is Dr. Tak-Shun from United Hospital, Hong Kong. Today, we are very honored to have invited Professor Bryan YAN from the Prince of Wales Hospital to talk to us on this newly developed technology of the adapter system, new STEM platform. First of all, let me introduce Professor YAN briefly. He's a good friend. He's a very competent interventional cardiologist. He was trained both in Australia and subsequently in Mass General Hospital, and has been awarded the Young Leadership Award in Interventional Cardiology from the Cardiovascular Research Institute in Washington, D.C., the United States. And upon his return to Hong Kong, he actually has performed a lot of peripheral interventional procedures at the Prince of Wales Hospital. And currently, he's performing the largest volume of complex endovascular procedures for critical limb ischemia in Hong Kong. He also published widely and lectured widely, being a number of chairpersons and presenters in various international and local conferences. So today, Bryan is going to talk to us on this DynamX bioadapter system from the clinical data to the Hong Kong experience. Bryan, please go ahead.
Cool. Thank you for the very kind introduction. So I have the pleasure of sharing with you some of the early clinical data and Hong Kong experience with the new DynamX bioadapter. For those who have not familiar with the adapter, is a novel uncaging design. So basically, is a drug-eluting stent with some elements which, with time, would sort of dissolve and bioabsorb and therefore unlink the stent. So the stent is can in a way become more dynamic and move, and that's some unique properties and advantage with that. So all in all, when you use the stent, it delivers like a normal DES in terms of deliverability, the implantation, and the radial strength technique. And then over time, then the uncaging element will absorb. And so it's a thin strut chromium as you expect from a current generation DES. So what happened is here, you can see when the stent is delivered, it will be caged, so it will be like a normal stent. But with time, then these elements would unlink, allowing the stent to, in a way, become more dynamic and move with the vessel. The benefit of that is aim to preserve the positive adaptive sort of vessel remodeling. So if you, on the top, you can see when you put a DES, with time, the stent will stay the same. It doesn't change. The device, the diameter and the vessel size will remain the same. But when in the DynamX bioadapter, when you uncage the stent, therefore, with time, that allows the stent to move with the vessel, and therefore, the vessel diameter will increase with the vessel, and also will increase with the vessel size, and the lumen hopefully maintained. So these are some of the data from the early mechanistic clinical study which has been published, and looking at the change in the vessel and the bioadapter and the lumen size. You can see here with time, then the vessel size does increase. The adapter area also increase, and therefore the mean area of the lumen maintained the same. So this is a static OCT just demonstrating this sort of phenomenon. So basically, by uncaging and restore the vessel function in terms of the pulsatility and also vasal motion. You can see that actually the stent moves dynamically with the vessel as it goes between systole and diastole. You can see a significant change in the volume or the area of the stent between systole and diastole, demonstrating the ability to pulse with the vessel. And also with vasal motion, that with GTN, and therefore you can see the more significant increase of the vessel diameter and the lumen diameter with GTN compared to a caged stent, which is similar to a DES. So the DES will not change, but with a bioadapter, it can move. So this is another way of showing is that we saw the vessel compliance. You can see on the left where when it's caged with all blue, meaning the area is more stiff, and then when it's uncaged, you can see it's less of that blue and more orange, because as the vessel is allowed to be more compliant. And also with in terms of rotational motion, that in a caged stent, it was rigid, it doesn't rotate, but whereas when it's uncaged, it allows also that rotational motion as well. And also this is another way of showing an angiographically is that it allows the stented segment to restore its normal angulation. So you can see some of this mechanism studies showing that after stenting a angulated vessel, it becomes straightened, but with time, because of uncaging, allowing it to move, then it restores to some degree the angulation of the normal vessel. So these are all mechanistic. So what we did is before we had a pre-marketing registry, which is run at 4 sites in Hong Kong, both Prince of Wales, Queen Elizabeth, and Michael was the PI, and also Queen Guanghua and then Queen Mary Hospital, and we did 50 patients. So the first 50 patients was really a very simple lesions, essentially type A lesions, and what we're trying to show is basically very simple, that the stent actually works and it's safe, and pretty standard clinical endpoints. So we did the first 50 patients, pretty standard sort of patients you will see in terms of demographics, about 30% diabetic, and we have about 50% stable angina and 50% of unstable angina. In terms of lesion characteristics, is pretty majority is type A lesion, a type B1 lesion. Because of design, we aim for some more simple lesions, and because at that time we only allow for one stent length, one stent without overlapping, so we only had for mean lesion length of fairly short. So in terms of 12 clinical outcomes, essentially you can see here, you expect a stent to perform well, and it does. So the performance is similar to most DS. You do not see any early or up to 12 months clinical event. So this is just one demonstration, one of the case we had, case number 6. So this is, in fact, a little bit more pushing the envelope a bit because the lesion was slightly more calcified than you would expect. We're able to dilate it with an NC Scoreflex and then put in a 3.5 to 28 millimeter biopdepta and post-dilate. And you can see the acute result was quite acceptable, as you expect. And also a 12-month follow-up, then it is pretty nice. So what we did, which is a bit unique, we did again, try to demonstrate the changes in the vessel and the device area. So we did an OCT run, and we did demonstrate that a 12-month follow-up, there is some increase in the vessel area and the device area, about 4.5 and 9.79% respectively, which is similar to the mechanistic study. So again, we demonstrated what the mechanistic study have shown, that the vessel area and the device area does increase with sort of maintenance of the lumen area. So we also did a static OCT run. So basically, we stopped the OCT from actually pulling just at the same spot, doing this diastole at the same spot. And you can see here there is some dynamic movement of the biopdepta. You can see here in the mid segment of the biopdepta, there's a luminal area increase about 10% during diastole. And by calculation, this may translate to an expected flow change about 21%. We also did this at the more calcified area in the proximal where we used the NC Scoreflex. So you can see this area a little bit more calcified, but also shows increase, but maybe a little bit less. But you can demonstrate that even in calcified area, if it's adequately prepared, then the biopdepta also demonstrate an increase in lumen area. Maybe a bit less, but there's still some increase, about 5%. So this is really just the first 50 very simple cohort. And then from this, we learned that the DynamX biopdepta showed pretty good acute performance, and then have excellent safety through 12 months with no clinical endpoints, and then demonstrate positive adaptive modeling and restore the pulsatility in phase of motion shown by our static OCT. And this is what led to the approval for marketing in Hong Kong. And so following to that, going to follow up to a post-marketing registry, and we're just trying to use the biopdepta in a more real-life situation, not just type A lesion, but more real-life situation, and allowing a bit more flexibility for more clinical use, and with imaging follow-up, OCT or IVUS. So the reason we can do this is that now the DynamX can be post-dilated a bit bigger. For the first registry, only allowed about 0.5 millimeters post-dilatation, but you can see here with the IFU and the bench testing, the performance and the extension is probably more in line with what you expect from other DES, so you have a bit more freedom to post-dilate to the vessel. So just showing some cases here again, just recently we have an ACS case. So we have a lesion, we pre-dilated and put in a 3.0 by 38 biopdepta in the LAD, and we're able to post-dilate the 3.0 to 4, which we couldn't do in the first pre-marketing registry. So it is more real life that you can use it in vessel with a bit more discrepancy, and see it's fairly good outcome as expected from this stent. So, and you can see here just quickly the I've showing that a very good apposition expansion from a 3.0 bulb depth to go up to about 4.0, so it's quite nice without any disruption. So you can see that you can accommodate vessels, and also overlapping is okay. So we're able to we can overlap just like what you expect for a normal stent. So this is the case also courtesy of Dr. Tak-Shun from United Christian Hospital. So this is a bit more complex, okay? This is probably completely excluded from our registry initially. It was done in inferior STEMI K, was thrombolized, and then had the PSI following day, and basically show a very calcified proximal RCA lesion and diffuse disease distally. So pre-OCT showing, you can obviously see quite a lot of calcium. Also need preparation before you put in any stent, regardless is DES or biodepta. And so it was prepped adequately with a shortwave balloon, 2.5, the mid and 3.0 proximally, and further post-dilatation. Very good, adequate preparation. And with that, you get a good result. So this is the OCT after your prep. You can see the cracking of the calcium with the shockwave and the pre-dilatation, and the stent performed fairly well in that regard. So, and this is done also with overlapping as well, okay? So, and then open up with the OPM balloon with good, excellent angiogram result. So we don't have any follow-up at this stage. I'm sure Dr. Trung may have that later on. So you can see here in post-OCT, and you can see the bulb depth actually have very good angiogram result. Therefore, it shows that, although it's not intentional, but in a more real-life calcified lesion, in even a STEMI case, then you get a good angiogram result with this. And this is also credit to Dr. Ho and from Singapore. Then he has actually presented some of his series of bulb depth in prime PSI in STEMI cases. And this is his first 36 patients, all in STEMI cases. And you expect it's more complex. So basically, pretty standard risk factors, and he predominantly used IVUS in most of these cases. And he basically showed that in about 36 patients in using the bulb depth in STEMI, then he has very good clinical outcomes, both at 30 days and at 6 months. So demonstrating this platform can be used even in very complex acute cases. And this is one of the cases from Dr. Ho, primary case. You can see here RCA STEMI, and then it's quite large vessels, and he put in a 3.5 by 38, and then you can see the result actually quite excellent in this case. And also he actually bring the patient back at 7 months for restudy angiogram. You can see here, what you expect from there's no restenosis. So from Dr. Ho, he basically demonstrated some preliminary experience with the use of bulb depth and demonstrate safety and feasibility in prime PSI with no reported 30 days, even up to 6 months MACE for some of these patients. However, obviously, longer follow-up is needed in a larger cohort to confirm the long-term safety and efficacy of this bulb depth in this indication. So the key takeaway from some of our more real-life case experience beyond our registry is that the use of bulb depth in more compilation is safe and efficacious in prime PSI from the Singapore study, and there's sort of satisfactory acute outcomes with adequate vessel preparation in moderate severe, so you can feel comfortable using the bulb depth if you can actually prep it very adequately, as has been demonstrated in some other cases. And also we have demonstrated in at least one case that there is resumption of vessel positivity at 12 months, even in a calcified segment. And then hopefully we'll get more data from our post-marketing registry with routine OCT follow-up to demonstrate this. And overlapping overextension is also possible now with this bulb depth. So therefore, we are going to start enrolling in our post-marketing registry soon. Hopefully we're able to bring you more results in the use of the bulb depth in more real-life, real-world clinical patients. So with that, thank you for your attention.
Thank you, Bryan, for your very clear and very nice presentation of this very promising technology. Maybe I can start by some basic questions first. When we were at the bioresorbable scaffold era, we were told to place overlapping stents on a stand-to-stand fashion without with as little overlap as possible. How do you do overlapping stenting with this new DynamX bioadapter stent?
Firstly, there's no straight answer because initially for our registry we actually didn't allow overlapping stent, but we did that because of bailout situation. But I think because the only thing that encages is the links. So the majority it is still like a DES. So I think you'll probably overlap like a normal DS with some minimum overlap. You don't need to do like the BVS or things where you do end-to-end like that. Right. I think you, in all intents purposes, the deliverability and how you use it will probably like a normal DES. Just be mindful of the linking. Maybe, so that's what we want to know in the post-marketing, to allow more overlapping, to show an OCT at the overlap side and the other side, whether there is some difference. So they may tell us a bit more about whether, how much you can overlap. So that hopefully we'll have the answer to that with our next study.
How about bifurcation lesions, when you have a significant side branch that you want to protect, or even, I don't know, add in one more stent? How would you do that?
Okay, so I think again for our registry, we actually excluded a lesion which require a two-stent technique. But I think it's okay for you to. We have done a case where you actually just probe out the side branch. I think, but I think mindful that you probably can't overdo it. I think it's okay. I can't remember. It's about 2.0. It's okay. I think even 3.0 is okay. All right. It don't. Obviously, if you have a big enough vessel, probably won't use it, because if you have a 3.0 vessel, you're probably thinking of a two-stent technique. It probably is not the best scalp to use. But it's okay for bailout. For a side branch like 2.5 or
Can you do kissing balloons?
We've done that with just a kissing balloon. We've done that. Okay. Although it was not in the our inclusion, but for bailout, then we've done it and has good outcome, and we've shown that it's possible. So we'll hopefully get more and more of these sort of experience. Exactly, you say, all this real life situation which we face every day, we need this bioadapter to perform. So hopefully in our post-marketing, we'll do all these, side branch, rescue, overlapping, all that in a more real life situation to demonstrate that it works as well as others. That's what we're probably more interested in knowing.
Well, thank you. I know Dr. Chung has been performing a lot of ACS, AMI interventions with this DynamX stent. Do you have
for this stent, because we have the advantage of the linkage and so during the primary PCI, actually we not really know the vessel size for this kind of case. So I think this kind of advantage can be shown in the late time after follow up the patient. And also during the primary PCI, actually, for example, the LAD case, we may also face the problem of the bifurcation, for example, the diagonal. So for this kind of case, I will also do the gel balloon technique and also the port-side port technique to protect the diagonal. Finally, at the moment, I can say from my case, the outcome is not bad, similar to a DES. But for the long-term result, I don't know yet, because it only appeared in my hospital for 3 months. So I don't know the long-term outcome at the moment. So, but at least the acute result is very good for this stent. And also, I'm also using this stent for young patients, so that when later there's if we have chance of, for example, stage PCI or the patient has another event, we can have look for this stent, maybe, I don't know.
We know in the setting of STEMI, the vessel may be constricted because of a lot of adrenaline secretion. Do you purposely upsize a bit of this stent as compared to patients with stable angina? Yes.
If I'm doing this primary PCI procedure, usually I will using the 3.5, the tip of 3.5 tube. Because as you said, the vessel size is actually constricted during primary PCI. So I will more tendency to use the 3.5 tube than the 2.5 tube. So this will have get the better advantage for the uncage for this vessel. Yeah.
But I think the other advantage would be the ability to uncage, so that actually you will allow the stent to grow a bit together with the vessel as the patient becomes more stable. That's one of the advantages of this newly developed uncaging system of the DynamX. Great. So thank you again, Bryan. That's a great talk, and we have to close this session. And Dr. Zhong will announce the result of the last competition.
Thank you. So I would like to announce the result of the last competition is the Malaysian colleague, the iatrogenic CACTO preparation with no cardiac tamponade, the Suhasya Nantistarari.
Great. We will contact you for the prize later on. Thank you. So this ends this sponsor session by Elixir Medical, and please stay on for the next session. Thank you.